Hi everyone. Thank you very much for taking the time out of your day to listen to my Overdenture case success webinar. Just want to let you know that the CPD QR code will be at the end of today's presentation. So just hang on for that final slide so you can claim your CPD. For people who are not familiar with CORS, I will start off here. Just want to introduce who CORS are. So CORS we are known for our surgical guides and we're full arch experts. We are also a very rapidly expanding dental laboratory service as well. So that's on Crown and Bridge and on the prosthetic side as well. And for the people who don't know who I am, my name's Sarah. I've worked in the industry of prosthetics for the last 30 years. The last 24 of them at Manchester Dental Hospital, where I headed up the prosthetics department. So during my career, I have been specialising in the area of implant retained overdentures. So I have had experience of a whole variety of different attachments, different approaches, and different clinical needs from those patients. So let's start off with success. According to the Oxford English Dictionary, it is the accomplishment of an aim or a purpose. Also, Albert Hubbard, in his writing to his message to Garcia at the beginning of the 20th century, said, "The line between failure and success is so fine that we scarcely know when we have passed it. So fine that we are often on it and don't even know it," which I think we as dental professionals can wholeheartedly agree with that quote. We have the times, we are striving for the success, but to actually miss achieving our set out aim or objective to it. So to be able to achieve success, we need to know what our objective is. So the question we need to ask ourselves, what is the treatment objective that we're heading out to accomplish? So the answer basically is to provide a functional, retentive, aesthetic, and a cost. We are going to be just acknowledging that the different types of overdentures there are. So there's two main categories of them. So there's the RP4, and those are the overdentures retained by attachments with some anterior and posterior ridge form. And the RP5 are the overdentures with superstructures. So these are supported by both soft tissue and a screw retained bar, which creates a splinting effect on those implants for you. And also in cases where there's very limited anterior posterior ridge form as well. So basically flat. So what's the pros for overdentures? Why do we go for the overdenture? So a lot of the time you can place fewer implants. That leads on to smaller lab bill and overall expense. Quite often as well, if less bone surgery is needed before the actual placement or during, so less invasive. Implant placement can be more lingually positioned compared to if you were doing an FP restoration. So therefore, again, saving expense, surgery, complexities as well. So that's also to be considered. They are generally easier and cheaper to maintain as well. So if they do need some maintenance, if there is significant wear and things, we can actually quite easily repair them. Quite a lot of the time they are used whenever FP restorations have failed as well. It's always useful to know what your removable overdenture options are. And also they offer really great ability to restore or enhance that facial aesthetic as well. So, and that's by using that label contour of the removable appliance, especially whenever a lot of the aesthetical fullness has been lost due to the bone resorption over time. And also they are quite a useful tool to help manage, especially if your patient is looking for a full arch restoration, but they have got nighttime bruxism as well. So again, that's something you definitely don't want to be with your FP cases. So why would you not have an overdenture? And a lot of the time it comes down to the patient's perception. They want to get away from that denture. They want to have something fixed, something like their natural teeth again. Whenever there's limited height as well, so limited space, there is that long-term maintenance as well. There is a certain amount depending on the variety and of bar and componentry that you use, that there will be. If there's continued bone loss as well, in the posterior section especially, and there's always that possibility of food impaction. So again, it's like everything, it is trying to make those informed decisions for your patient, sort of thing. So let's have a look at the analysis. So we need to start gathering up the information and the factors which are going to influence our design and our design choices. So there is that initial conversation that the patient, the clinician has, is about the restoration type. So it's from the patient's perspective, what are they expecting? And also it is from the perspective of the clinician as well. So it is deciding from a more of a medical technical background is what is suitable for that case. So these are the things you would be looking at: is the bone quality, the possible implant placing. We've got to look about function as well. So we've got to consider what is in the opposing arch. So if it's fixed or mixed indentation. So things like that, because that will ultimately have a huge bearing on the actual or possible displacement of the opposing arch as well. So that restoration. You've got to look at possible sites for implant placement. Is there going to be sufficient height? How many are we going to place and what size are they going to be as well? Is the retentive element, are we going to be able to get them to be parallel to one another? We need to take that full 360-degree view of that restorative space as well, to be able that we can actually capture all of those sort of retentive mechanics in there, that bar, that retention as well. Got to look at masticatory forces, as said, bruxism, things like that we've got to take into consideration. And we've got to look at the skeletal and jaw relationship of the patient as well. So therefore, we're making a suitable appliance that is skeletally and functional in that patient. With having done this overdenture work for quite a number of years, I do get asked is how do I achieve a predictable outcome? And for predictable outcomes, it boils down to that accuracy and efficiency of my workflow, of what I consider. So where I start is by beginning at the end, really, and that is with a try-in or a trial of that final restoration. For one, it gives the patient an overview of what the aim is, and it also gives yourself and the technician, it gives all of the three parties involved that clear, concise end point that everyone is trying to achieve. So therefore, we also have to start breaking it all down into the factors that will influence that design of that restoration. And something like that, it comes with knowledge and time and experience. It's like everything is that we have gained experience from making mistakes, but also having restored successfully cases, but then reflecting back, saying, what could I have done differently? What would have done to improve it? So what would I do again if I had, if I had a similar case, sort of thing. So always that striving for excellence. Some of the questions I get asked on a very regular basis: is there enough space for a bar? And what do I think will work best? And this is where my knowledge, my experience comes in. It's fine because I can utilize that, but at the end of the day, I still break it all down to actually have a look to see. So this is what I want to sort of bring you into now, is looking at all of the factors that I am considering. So if we start off with the overdenture components, so we're going to start with our much loved locator attachment. So locator, extremely versatile. They are produced for the majority of implant systems that are on the market. They do offer you that ability to change the retention levels for the patient. They do provide a pivoting action of the insert within the housing. So therefore the standard inserts will let that divergence of up to 20 degrees, and the extended range will offer that up to 40 degrees. Again, it is marrying up if it is how parallel those attachments are going to be able to find that path of insertion. because these things is what we have to consider as well, is not just how parallel locators are going to be or those position attachments. So this goes for the same as for like any of the ball attachments that we have with Nobel or Astra as well. So we've got to have a look at what size their actual attachments are, and this is where we're looking at is that the locator housing within that denture is 5.45 wide. So whenever if you're fitting them chair side, that's the diameter of the locator housing. We're looking at a height of 2.35 as well. So that's the minimum that it needs. So we're not even talking about how much space you need for the retention that you need to add on. Sorry, for the acrylic to be able to add on as well. So Locator has got a marvelous little insertion tool. I think Straumann has got their own version of this as well. So we have got a tool that is basically that will place the abutment for you where you can torque it up to its required amount. And also the tool will actually help you, will enable you to put in the insert and also remove the insert as well. So it's a nice little investment. So that's basically sort of the standalone. As I said, all of the standalone, like locator and ball attachments, are more or less all of the same, you know what I mean, sort of premises. So if we just have a little look now onto the different types of overdenture bar structures. So bar structures come in a whole variety. So I've just narrowed down into 4 different types, really. So for the overdentures, I'm doing for 3. So we've got the Dolder bar, the Hader, and the hybrid 2-in-1. We also have a screw retained acrylic wrapped, not really an overdenture, but it's just a denture that is screw retained. So the Dolder bar. So Dolder comes in 2 shapes. There's the U and the egg shape. I am a particular fan of the U shape because of the parallel walls, which gives a good level of rigidity support to the denture whenever it is seated. The egg shape is more for resilience. Again, I'm not a big fan. It's one of those things is everyone's got their own personal preference. I've had a lot of success with the U shape. So therefore, as like a lot of things, I don't try and over engineer things. So with the U-shaped Dolder bar, it comes in 2 sizes, micro and macro. You may not think it's a huge amount of difference, but whenever it comes to height, we are looking at 3mm in height requirement for the larger of the macro, and then a 2.3 for the micro. And again, whenever we come to looking at width, we're looking at 2.2 for the and 1.6. So these elements may not sound huge, but whenever it comes to restoring, though that millimeter, that 1/2 mil here, 1/2 mil there is really critical to obtain that final successful outcome. So that's one thing to consider the bar, but then we've got to think about the clip, the retentive element itself. So again, we have each the macro and micro. We have the height again for that. That will come and sit to the base of the bar. So therefore, that overall height, we can see in A here is 3.3 or 2.75. And that width, we can see is steadily climbing up. We're now at a width of 2.8 for that, and then 2.1. So it's just keeping that element. So it's keeping that an eye on those crucial factors, because here we have to have a look at the retention. So here we have the retentive housing. It's flared out on either side, and we're popping up to almost, well, we're at 4.6 for the large and 3.6 for the micro version. So all of a sudden, we're getting quite a wide restoration in there. So here's just some examples of the actual bars themselves. So we're looking at the Hader bar. So the bar is this classic shape, is this circular shape with a skirt underneath it. And it's basically a spin-off for what, if for the older people, if on today, will remember is called the MP bar. And this is what we used to cut sections, preformed plastic, and we used to wax them together and then cast these into gold many years ago. But they have, it's a very successful profile of bar shape because of the rigidity it gives and the longevity of the actual wear of the appliance as well. So that round section there is a 1.8. So whenever you come to looking for attachments, this is what you've got to have a look at, because the attachment just clicks on to the actual circular section of the bar. Whenever you come to making a header bar, the general rule of thumb of manufacturing is that you would not, for a span between the implants, you would not have it any greater than 22 millimeters between the actual implant abutments. And a distal cantilever, you wouldn't have any longer than 6 millimeters. And that's all to do with the forces that are being transferred onto the bar itself from the restoration, which are from masticatory loads. So this is where a common fracture point is here at the junction of where distal cantilevers and where they join on for the screw access cylinders as well. So it's things like that you have to be very aware. So in the cases that you don't, where you have a spanse, in this case here, we've got an anterior saddle area that is greater than 22 millimeters. We need to have a look at as well, if we go back to the header just for a second, the header, it is basically just in straight sections. They're not designed to be put into a V shape or a U shape. But if you want to still use the 1.8 clip profile of the header, again, what you would be looking for is the Pressahoric bar style. So it's basically a solid bar that has the section milled in. And these sections are 6 millimeters in length. And you have your 1.8 for your diameter of your rounded section of the bar, and then your 1.3 for the under section as well. So that's sort of height and your minimums. You can see on more of the premolar area here, you can see where that profile is getting quite short and there's not a lot of excess material, but this is giving a more rigid and durable bar structure. But also with this type of Pressahoric style bar, you can actually have distal cantilevers that are up to 14 millimeters as well, which is quite significantly, it's more than double of what you have with the header. And that is all to do with the fact is that they can actually, with the design of this bar, is that we can actually enlarge this contact because of the milled sections that are just milled into there. So therefore, it has got the strength to withstand a fracture. Whenever we come to looking at the retentive element, so the clip elements, we've got a few options for the 1.8. We have the MP clip. So here we have the actual insert. So this is the metal housing. And the reason why we have 6 mil wide pre-milled sections is because the clip is made and manufactured in these. It is not designed to be sectioned, to be smaller. You can put two beside each other. If you're careful, sort of thing, you can have a section that is milled like 12 or put them, but it is in the increments of 6s is what we're working at. We do actually have here is a gold Ackerman clip. So that's a resilient clip. So therefore it sits passively until there is a displacing force applied onto it. So therefore that's whenever the element, this lower section of the bar here will actually engage, because whenever we are manufacturing it, we put this little gold spacer rod in here. And then whenever we take that out post manufacturing, so therefore there is a space, there is a gap for that. So therefore that clip will sit passively and offer that resilience onto there. But again, you have to have a look at the size portions. So the Ackerman, you can see, is taking a 3.7 for its retentive element, where in comparison, the header or the MP clip with the insert is 1 millimeter overall. Another what you can use on the 1.8, so either the header or for the for the Pressahoric bars, is you can actually use gold clip. Gold clip comes in, I think they are all 50 millimeters. I don't know if you can buy a 25 mil. These can be tailored to be customized to that saddle area. So if I just go back quickly, so therefore we can actually cut a section no matter what length that is. And we can actually use the full span of distance of them, so we can maximize that retention level compared to if we were using the MP clip on there. And also we can actually use a combination. So if we are in a situation where the implants have been placed, we've been left with a very narrow saddle of bar at the front at the anterior section or elsewhere, we can actually use a combination of the pressahoric either side, so easy upkeep, and then we can use a little bit of clip at the front again, just offering that little bit of AP resistance and displacement on there. So just as I was speaking before about the ball attachments, again, we have to have that consideration. So standard ball size across quite a lot of the implant ranges are 2.25, which is great. You don't think that's too high, but by the time you've put the housing on, you will have gone up to 2.65. So that retentive element on the top there is 0.4 of a millimeter. So you have to have that allowance underneath your actual denture teeth and within that denture profile. You can actually put the locator attachment onto a bar. Like previously we just looked at here, you can actually put the ball attachment into the bar. These are tapped in, so therefore they can be unscrewed. Same as locators, these are basically is a bar that is milled with and the thread is an M2 thread. So that is tapped in there, and then you order your attachments and you basically torque them. The technician will torque them onto the bar. But again, you have to, that actual locator profile itself is a 3.86 millimeter wide and with a height of 2 millimeters. So it's those considerations is what we have. But you can have a look at this case here where you can see I've taken away the soft tissue here, and you can actually see where the angulation of the implants are. And this actually gives us a very nice parallel platform to actually have our overdenture being retained from it, sort of thing. But it is being very aware of, again, by the time we have the locator housing on. So here we are looking at that is, even though the actual locator itself is 2 millimeters, realistically it will be 5.45 because we need to get the retentive housing on there. Plus we need to get acrylic and we need to get the denture tooth as well. This is going down a little bit more complex, and as you can imagine, needing a quite substantial amount of vertical height. So these are 2-in-1 hybrids, or the two-part. So basically you have a permanently screw retained bar section, and here we have a superstructure, and it is has seeker attachments. Seeker, I don't know if any people who know have used seeker attachments, is that you basically seeker site, which is a cement, you basically seeker site the pre-manufactured little cups into the pre-milled section of the bar itself. So therefore this is, and then we seeker site the seeker attachments, the male sections of the seekers into the underside of the sleeve. But these can be adjusted, so they are like a splay of 4, so therefore you can actually splay them or tighten them together, and you can also change them as they wear. But they are considerably, they do take quite a lot of height. Very good for cases of patients who've got very high masticatory loads, but they do need to have that quite substantial vertical height as well. So in this case here, you can see where we have extended the saddle, the actual sleeve as well, or the superstructure as well, so that we can actually extend, again, eliminating the AP and being able to do a full arch restoration as well. One of the beauties of the overdenture bars as well is that we can actually work on either a combination of fixture level or abutment levels, and then we can make everything parallel. There is a certain amount of parallelization that we actually do need from these. There are limitations, but then again you will find, and you'll actually discover that whenever you've actually doing your vacation jig, if this is a possibility as a 1 unit. If it's not, we can actually section these and have these as a 2, and we can mill them as a 2 unit. So we have a bar section one side and another, but then the overdenture will slot over both. So you're not losing out too much on that level of retention. I think this case here that I'm showing is for a zygomatic case. But with the pressahoric bar here, is you do actually follow the nice contour of the ridge as well. So we're keeping that bar within that restoration. We're not creating unnecessary or avoided palatal bulk as well. So here is another little case that I've done in the past. Again, this is for a zygomatic case where we have the ball attachments that have been screwed, torqued into the bar itself. You can actually see here is that we can actually set low the attachments. They don't have to be on the high side, the flush side of the actual bar itself, as long as we have enough space for the thread to be fully engaged with the attachment. That is absolutely fine. So you can countersink them. And also, on this case here, is because the implants are so anteriorly placed, we have actually used the header profile or the pressahoric profile on the vertical axis. So there you go. So you can see the housing on the picture here on the right. So you can see that this here will reduce and did reduce the level of AP rock than by just using the anterior section with just using the ball attachments on the front. This was a very nice solution and it created a very solid restoration. So one of my top tips for this evening is, and for the ease of maintenance, is all of these things, is patients whenever they have bought into this and had this extensive amount of treatment and everything, they predominantly look after them. But there comes a point where we have to do maintenance. So one of the first things I will, whenever somebody says I need to make a new denture for a bar retained case, I will always ask is, have you got the original working models with the implant analogues? And if the answer is yes, we have just made things so much more easy, because otherwise we have to do impression pickup of, you have to either remove the bar and actually obtain the impression pickups and actually pick them up so that I can cast impressions. So we have that working model so that at the final stage is I can actually put the patient's current bar onto that model to be able to process the overdenture. But this is something, so if you have got patients who are having these, is to give them the model and just factor that costing of the analogues and everything into it. So whenever it comes from the technical aspects, whenever it comes to actually deciding, whenever people say to me, what sort of bar would I recommend? So what would I suggest for this case? This is how I come to that decision. So everything we can have like a bit of a knee jerk. I would like a hater or I would like a dolder. But how are we going to fully decide, make that final decision? And this is where my little equation has come into, is that we want to establish that restoration, that final product. So we get that occlusion, the profile and the aesthetics all nailed down. We're going to make a verification jig to make sure that our master model analogues is confirmed. It's been verified that it is an exact copy of the implant placement and angulation actually in the patient. And also we are going to conduct a 360 space analysis as well. So that negative space, so that's a visual inspection. And also we are going to consider the actual dimensional requirements of the componentry of that bar as well. And it's only then that we will actually start making the implant bar itself, when we're going to actually design it, because we do not want to start making any vertical changes, any registration changes post-construction. So this is a little method that I've used over the years to give me that 360 negative space analysis. And as you can see is that the example on the left, we're happy days. There's absolutely loads of room, loads of space. Great. You know what I mean? We don't need to worry too much. But unfortunately, they're not all like that sort of thing. The picture on the right, you can see that this is bounded. I think this was actually for screw. I think we end up doing a screw retained for this case because of the limited height that we had on this as well. So it is that, so we can actually see how much space have we got to get everything into. So these are the elements whenever you come to break it down, is what is actually made up. So this is where I think everyone can sort of think about whenever they've been to Subway and they keep asking you, do you want this in your sandwich? Do you want that in your sandwich? And you keep going. And whenever they come to fold over the two halves, it can be a bit precarious, you know what I mean, to actually, of them trying to get everything without it all falling into the wrapper itself. So this, we need to identify the abutment at texture level or abutment height. What sort of angulation are they going to be as well? What platform are they on? So different platforms have got different sizes. So therefore we have to be quite aware of either their MUAs or they are uni abutments, either 20 or 45 degree, depending on the make of the implant systems. And we also got to take in mind is that the height of the implant screw head. So the lowest point that you'll have a bar made is going to be at the top of that screw head. You'll never have a bar, or you should never have a bar made that is actually exposing a screw head, because it leaves it vulnerable. There is no way of putting some composite in, so therefore it can be easily retrieved later on. So therefore that is the minimum height that we're looking at. So that's the minimum height from your highest abutment. We have to look at the parameters of the actual removable bar itself. So we've just covered the majority of them, about the different types of header, pressihorics, if it's going to be a 2-in-1 sort of hybrid, what sort of gingival adaptation and a clearance. We still want to make sure that the patient is able to clean underneath. Are we going to have, what sort of clearance do we need to enable that? We're going to have to look at the retentive elements like we've already done. But we need to be able to glue it all together. And that's where our pink acrylic comes into it. But we're trying to use that pink acrylic to glue together the retentive element and the denture teeth, and to restore the aesthetics as well. For an overdenture, I believe that you need to have about 11 millimeters between the soft tissue and the occlusal plane. Ideally, it would be great if we could have 50 millimeters. That's if we are going to, those are the ideals, but unfortunately we don't always get that. But there are methods and there's techniques around that we can actually utilize to achieve success. So let me just move on to, I just want to show you quickly just a little case example. So this is just a full case. The lower is a locator retained, but I'm going to talk about the upper. So you can see here is that I have established what the final restoration is going to look like. And on here is I've made a pressihorics bar with these 6mm retentive elements milled into it. This is due to the fact is that this span's here, this anterior span's been over 22 mils. But also, as you can see, whenever I've processed these into acrylic, is that you can see that pressihorics is nicely following that arch shape. So it's sitting nicely underneath the teeth. So therefore, that palatal contour is nice and smooth. There is no unsightly or uncomfortable bulk that has been added onto that actual final denture. So the patient is not having to deal or to adapt, or it'll affect their speech or their sound making. So therefore this is, you know what I mean, a lot of the time I prefer this because of that. Also is where we can see, if I just go back a slide, is that we can see that the bar itself, I didn't add any distal cantilevers onto this case, because we're going where the bar itself is going as far back as the 5s. So therefore that distal cantilever is not really needed. We've got 4 very nice little bar sections. You can see as well, whenever I come to blocking out the bar as well, is that I am quite attentive whenever it comes. So therefore this is helping the path of insertion of that denture into place. Therefore it's guiding it. So therefore the patient doesn't have to too much free, struggle of actually getting that placed correctly. So the next part of the presentation tonight is going to look at the workflows that we have here at Course 3D for the Overdentures. So I am just going to come out of the presentation just for a second. But first of all, I just want to run through just what the workflow variables are. So we all work in different ways, and there's a certain amount of variables that we have included within our workflows. So there's the cases where for the overdentures, if we're going to do a chair side or a lab fit, so those are for the locator or for ball attachments. All of the actual bars are lab fit, but you've got the choice of what base material you want them in. Is a mill PMMA or printed loose tone or conventional PMA. You can either supply digital analog records. You can have this for new or existing locator abutments that in the patient, or if we are going to be basing that 360, that final restoration on a existing denture, basically if it's suitable for a copy denture style, or we're going to start from the ground up from registration room. So just let me pop out of this quickly, and I'm just going to go into the course website, which I'm sure some of you are familiar with. So what I'm going to do is I'm going to go into find my workflow. And this is where we're going to be asked our variables. So let's start. So what am I making? So this is the same workflow where we have workflow finder tool works also for full and for partial denture cases. So let's start with an overdenture on locators. And what are we going to do? So with these locator inserts, are we going to do them lab fit or chairside? Then next, let's select a base material. Say we want to go with printed lucitone. How are we going to submit those initial records? And we're going to send them by an IOS of the soft tissues of the arch that's going to be restored, and then also the opposing arch as well. So next question is, does the patient have an existing denture suitable for the use of the copy denture technique? Again, this is sort of wildly debatable at times. So what we have done here is we have given the option of not sure. Help me decide. So what changes are required to the aesthetic of the existing denture? So we do allow some. So it's things like, is there going to be an increase in the size length of more than 2 millimeters? Centerline change, is it going to be a cant alteration sort of thing? Or are we altering the percentage of pink tooth ratio? So say there are going to be no changes or only one. So say we're just changing a cant, say. So we're just going to do. So are you going to be increasing the OVD by greater than 2 mil? Because if you say yes, you will be brought back and basically be told that you don't have actually a denture that is viable for the copy technique. So if we say no, are we going to be changing the occlusal relationship from either a 2 or 3 to a class 1? And the answer is no. And again, so this is where we are ready to be shown our workflow. So we just click on workflow and we just do download your workflow. So here is our workflow. So for this case, as we said, it was going to be a chairside fit of the locator. We were going to go with printed lucitone. And then we get the choice of either lucitone teeth or with Enigma Life teeth as well for that. And the records are going to be submitted digitally to us. And we have got a suitable copy denture, an existing denture at that, which only needs minor adjustments. All right. So the first stage of that appointment number 1 is going to be to perform a reline with a light-bodied silicone impression and have the patient perform those functional movements. And then whenever it's set, you're going to remove it and you're going to evaluate and trim any excess material. Then, as we said, we're going to do digital records on here. We are going to capture using the iOS, a 360 of the actual denture. Then if it's a single arch, we're going to just do an iOS of the opposing arch and the bite registration. And if it's a dual arch, we're going to do an iOS of the opposing denture as well, and the bite registration for the 2 dentures as well. Then the next thing you will need to be doing is taking the shade. Ideally, if you have the Shotlander Enigma Life tooth shade guide, you can buy them from Shotlander themselves, or they are very closely matched to the Vita shade guide. That's great. And also send us a photograph of the patient with the reline trying in the mouth as well. So therefore we can actually see the actual patient. So it's this full facial smile photograph with the existing denture in situ. That gives us, as technicians, and whenever we come to planning and designing the actual denture, is that real clarity of what we are aiming for, and just aids and supports our decision making at the bench or at the computer. If you require new locator abutments to be supplied, please measure the gingival height, tell us what type and platform that you're on, and we can supply them for you. We can supply you the originals, and we can also supply you the IPD compatible versions. Just let us know. Again, this is all in our prescription. And as I said, the photograph can be submitted either through the iOS or through the course online prescription, or it can be emailed to dentures@course3D, but please remember to put your name and the patient's name on there. That'd be great. So as I said, the iOS can go directly to us, or they can be put through on the Course3D actual portal as well, or they can be emailed to us at Course3D, but a lot of the time the files are quite large, so therefore it is best if we either use the iOS portal transfer or the actual online ordering system as well. that we have. There's where you can attach on. So part of this workflow is that it is a 2-stage, it's a 2-appointment workflow, but you do have an option for a printed try-in, but this is at a additional price. I think that's standing about 75 at the moment, £75. But you will get a 360 design loom from myself or from one of my team here, who once the design has been done, you will have the opportunity that we will actually talk through the digital setup with yourself before we go on to manufacturing. So that decision can be made or anything. We can have a look at overbites and overjets and the occlusal contacts and things like that. So whenever and then your final appointment will be the fit appointment. So if you've got new abutments, you position them. Then we have the locator chairside guide as well, which is on the website as well within the impact denture. And also this is where you do your final fit of the denture. You cure, obviously they're all cured inside sort of thing, and then you review your case in a couple of weeks' time. So that is basically what the workflow for this case would be. And they all vary depending on what we're looking at. So if we had a case, so I'm just going to go back out of that. So say you've looked at your workflow and then you want to submit the case. This is where you would start. So if I just, before I do that, I'm just going to run you through another workflow. Find my workflow again. We're going to do things a little bit different this time. So we'll go on a locator. We're going to do a chairside fit again. I would say we're going to do conventional, but we're going to submit it by analog records. And then this is going to be, so basically it is going to be a conventional. So I know some people, and I know we have got tried and tested ways that we know and we trust that we can produce a really good product from. And again, this is a 4-appointment stage, because whenever you choose that conventional acrylic base with the Enigma Life teeth, your first try-in is part of the costing of it. And again, it is, you will be sending in analog impressions, again taking your shade and requesting if you need any new abutments or further locators. And then what you'll receive back at that second clinical appointment is going to be your hard-based rim. So this bite block is basically a hybrid of a special tray and of a registration rim. So you'll do that silicone impression reline of the tray section in the mouth. You'll evaluate and trim it. And then you will do your bite cord from there as well. So recording the vertical dimension, the occlusal plane, that center line for a sort of thing, smile line, probably a little bonus there. And just really contour that labial profile to the desired lip support as well, providing us with a silicone bite reg, and you will be posting that all off to us. If you had said that you were going to be digital records, we would be asking you to send us a 360. So it's a really good little tool if you want to have a bit of a play around with it and on what way you want to experiment with your records and how you could work with us here, of course, to play around with trying reducing appointment times, exploring just different workflows, how to achieve that final restoration for your patient. But as I said, you get a part of the denture try-in because that is part of the manufacturing process of the conventional, because you've done the conventional denture base with Enigma Life teeth. That try is part of the process of actually creating that final denture. So your cost will be for the posting alone sort of thing. And then finally, your final appointment again will be the chairside fit of the locator attachments, so with the denture and then that final denture checks as well. All right, so let's go back. And then whenever you come to submit a case, so this is where is our online ordering. So you can either walk through, find my workflow, or you can actually do this via the actual create a case. So you can actually go create a case, select impact dentures. Then you come to our actual, what's part of the impact denture family, what are we trying to. On here, what you'll find is, for the people probably wondering how much things are costing, you can actually have, before submitting a case, is you have your rundown. So you have your variables, your base material, your teeth type, the number of locators, chairside, lab fit, Then we have the mill PMA, conventional PMMA as well, and the chair side and lab fit on there. Whenever you hit that little link, it'll take you to all of the pricing for the prosthetics. There are some anomalies whenever it comes to overdentures. Is like we have the pricing currently is for bar and denture, but again, it is all very individualized. If you are just making a new denture on an existing bar, that's something that you'll have to email in to myself or to dentures@course3d.com, and I will contact you and I will give you a quotation. So just run this back again. So just to create a case, so overdentures on locators. So again, we're running through very similar to what we did. So with you, and again, your workflow option will be offered for you to download as well. So say you want to do a printed bliss tone, you are going to use Enigma Life teeth. Nice. You're going to do a chair side fit, and we're looking at, say there is going to be 4 implants. So here we have, it's already given you your standard price for that denture, and that is 515. So that is your denture and your housing, your location, and providing use with the locator housings as well. We're going to ask you what sort of records you're going to send us in. We're going to do digital, and again, if we do not sure of what existing, if you have a suitable existing denture, we will ask you similar questions again. So if we go no, this is going to be your workflow, so you can find your workflow like this and download it. Then you can print it off at another time. Then you fill in a bit, don't know, then better change. This is 26. Say we're going to be doing a upper arch. Again, we can just, and then put all the sites on there so we get that clarity of what we're looking at as well from a laboratory side of things. And we're just going to reuse the existing ones that the patient has. So the abutments, again, you don't really need this. We don't. And then we're going to say that the lab is going to be supplying the packs as well. And we just that, and then we're going to choose our shade, and we're just going to go for ordinary pink. You have got an option of adding so standard course anatomical contouring is included in the price, but you can actually have for an additional £85. We can for per denture we can actually add in some compositing, which is our course 3D anatomical contouring and compositing and layering. Or if you want a bespoke for 125 per denture, we can actually work from photographs or a recording to help create that actually more customized high-end finish for that patient. And then again, as this is for a digital workflow, we will charge you for the try-in. And again, we're just going to ask you how you're going to transfer. Again, if you have a photograph, you can drop it in here. You can tell us what ISO scanner you have on here so we know where to look, which portal that we need to, and then put in here any additional information. So if we're replicating any things, if the patient's got a diastema, things like that, you know what I mean, and any of those minor adjustments like amending a cant or changing a center line or anything like that, this is where you can put it in. So once you've said, you can add that to your cart. And then we have that digital shopping request, that digital prescription, all there ready. We do not ask you to charge, you will not be charged at this stage sort of thing. This is just basically starting the case and just getting the wheels in motion for us to start that and receiving it within the laboratory itself. It is something that, again, for each of the clinical stages, you will receive a paper copy prescription and just fill it in for the next clinical stages. So therefore, that is just the continuation, so the try. But our default, as you can see, will be from our workflow. So therefore, this is what's expected the next stage if we don't receive, you know what I mean, or if you just say on a post of something that this is whatever case and this is the next stage, go on to the next stage. That's what we'll do. So everyone's clear. So just one final thing I want to do is just run through the final workflow with you, and that is for the bar retained overdentures. So this is quite simple. It is just 2 clicks, 3 clicks, and here we are. So currently at the moment, you can submit basically analog and digital records of that for us sort of thing. There's quite a bit to read through. So at that first appointment is that you are creating those primary records either via ISO or by impression taking. So it is, and also establishing what platform that you're going to be on. Are we going to be on MUAs or at a fixture level? And if they are, whose MUAs they are. You're going to do your shade, and you're going to fill in the prescription either online, like I've just shown you, or via a paper copy as well, because I do believe some people have been sent out the actual docket book of prescriptions. And again, as I said, that if you do need any new abutments or anything, we can supply the OEMs or the IPD compatible. All right, so as before, you will be receiving back a special tray, which is going to be an open special tray to be able to pick up those impressions. I haven't got on here, but I will accept body scan to be able to produce that secondary model as well, but something that I'm just evolving at the moment. But yes, I'm happy to do that for people who are happy with intraoral scanning and have got a supply of UA scan bodies to hand, sort of thing. Otherwise, you will need to order the impression pickups or ask us to supply them for you. So the impression you're going to take is going to be either in a polyether material, so in an Improgum, right? If that is done with the impression material, again, you're going to get a registration book for that registration. Then it's all the conventional processes with the bite registration and the photographs as well. And if you have an existing denture, either take an alginate of that or do a 3/6 iOS of that, so we can copy that arrangement and get that tooth size proportion and everything. And then whenever you're returning anything, so if you're using any analog records or anything like that, please make sure that you're using the Course 3D free post label, and that is founded at the top of our webpage, sort of thing. So therefore, please make sure that you're using them so it gets us here safely. And again, please make sure that you've put in the impression, the pickup impressions and all of the screws for that, and the bite block as well, and include obviously your details and the patient's. So for the third appointment, we are looking at basically what we need is basically the denture try-in. So you'll get a conventional denture try-in and you'll get a verification jig. So therefore, you will be verifying that secondary model, even if it is produced from scan bodies. Either way, you will. And secondly, you have a conventional denture try-in. I will also supply you with a 3/6 negative record of indices of that denture setup as well. So that denture try-in. So therefore, you can make those informed decisions if you think that the teeth are quite labially profile on there and you want to have that bar, you know what I mean, to try and reduce any palatal bulk. We can have more of a look at a presihorix. If you need to have, you know what I mean, if you have no issues like that, you can just ask for a nice standard Dolder bar or a nice Hader bar, whatever way it works, sort of thing. So just for you to make a few more informed decisions, because every technician has their own preferences, everyone's had their successes and failures. So therefore, it's trying not to sway people against things because of their own personal experiences of things. So everything, if you need a re-reg or the verification jig is not correct, you'll section that verification jig and basically use that special tray, because you'll get your special tray back and you will re-pick up the positioning of the implants. And then we can also do you a retry, but then again, that is at an additional price as well. But these minor cost implications are very beneficial rather than going straight to fit for a bar construction and of denture and it not to be successful, sort of thing. Right, and then again, you'll be sending that on for back to Course 3D. So as I said, it'll either be for retry or the next stage will be the delivery of the bar and the finished denture. So again, it's like everything, you just need to tell me what sort of bar you like. If there's any time you suggest a bar and I either have any issues or any concerns about it, I will contact you to let you know. I will let you know as soon as possible, sort of thing. All right, because I don't like to send people down a path that is not going to be successful at the end. So I'm just going to pop back on the presentation. I just want to pop you over. So again, it's like anything to do with the laboratory. We don't like to stall people's cases. You know what I mean? And a lot of the time it is just from missing information. So ensure that we get that efficiency for every single case. So it's actually our poorly taken impressions. I mean, they're not a pleasant procedure to do, especially on some patients, harder than others. It's just getting that bite registration as well. Just make sure it's correct. We've got complete clinical record, that photograph report as well that we need, and just that insufficient functional information. So it's even the simple things like what denture-based material do you want, what type of teeth do you want, you know what I mean? It's one of these things is because that is replicated within the pricing of things. So please you take the time and actually have a look at our website there, and you can see what the options are. And if the option on there is not there for you, please just let me know, sort of thing, and we can see what we can do, sort of thing. And again, if things are unclear or missing from the actual prescription as well, as I said, please take a physical prescription. You know what I mean? After that first initial stage, you will be sent that out in the box as well. So therefore, please make sure that you use it and you use it fully, sort of thing, to make sure that all of the details are put in there. All right. So next one, as I said, we've already covered most of this, is with the sending and submitting the case. As I said, and as you're using and utilizing that for analog cards, make sure that we are actually getting the actual postal label, and also you can download the prescription, or you can request a lab docket book as well by emailing hello@course3d.com. Okay, so that'll be sent out to yourselves. And also here is just a quick little statement from one of our happy customers, from Neil Gordon, where again it was from surgery to completion. So this is a bar case we took. He was very pleased, and so was the patient, which is lovely to have recommendations and success at the end of the day, and that's what we're all about. Again, if you want me to come and talk to any of the teams, or to do an online lunch and learn session as well, I can come over, and I have got shortened versions of this sort of thing, and I can go through the product ranges that we have and how to submit cases and things like that, so we can tailor them to what your practice needs are. So a little bit of a preview, an exclusive. On the 3rd of March, James Hamill is going to be launching our full arch restoration in 2 appointments. And this is called the DigiBridge. Okay, this is from ourselves. It is basically a exclusive and a very ingenious way of guaranteeing passivity for that full arch restoration. So going to be another 1 hour CPD. So if you want to register, you have the QR code there over James's left shoulder. So you can take a shot of that now and get yourself registered on there. But yeah, it is a big exclusive there for you.